Okay, so what I'm going to be talking about today is it's nice to see familiar faces and unfamiliar faces in the audience. Welcome, glad you're here. What I'm going to talk about today, a lot of it comes from a previous study that I did that was about periconceptional exposure assessment, where we really did recruit people who wanted to get pregnant and measured a whole bunch of stuff about this. Okay? And so we'll start with some background.
Oh, that wasn't turned on. Sorry. And it's very rare that I feel tall, but today I feel tall. So winning, right? So what we know and what we heard from our last presenter is that there's a lot of evidence now that really early exposures, including exposures that happened when you were not even you, when like you were still segmented into the germ cells of your parents, might actually matter to you today. And we know that these can have long-term effects, and they could affect things like fecundity, like could your mom even get pregnant, growth, development. We want to measure this stuff, but how can we do it? Well, I went too far. So a lot of what we do are from cohort studies where we recruit people who are pregnant and then measure a bunch of stuff about them, because when people are pregnant, they're interested in participating and they go to the doctor a lot, or midwives, stuff like that. So we can access them. But even if we're starting at a first trimester visit and doing lab testing and all that stuff, we've already got bias, because who have we missed? We've missed people who didn't conceive. We missed people who maybe did conceive and had an early miscarriage. And that might be important and interesting too. So we can't forget that although every study can be helpful in giving us information, we still got to think about who's not there. Like, where's our selection bias? Where's our information bias? And what can we do better? So the selection bias is including people who achieve and maintain a pregnancy if we're studying pregnant people. We're also selecting for a population that's seeking prenatal care by a certain time. And maybe women who are on higher order pregnancies are less likely to seek early prenatal care because they're like, dude, I know where this is going, right? But also women who might be surprised to be pregnant may be less likely to seek early prenatal care. And so there may be selection bias there. And the information bias land, we might be underestimating miscarriage because we know a lot of those are just missed. And another thing is, if we are measuring exposures during pregnancy, some exposures that we care about might have already changed. I know not everyone in this room has been pregnant, but let me tell you, when you're pregnant, things that you used to enjoy, you might not enjoy anymore, right? And so we can't measure that if you're not being exposed to it. And other exposures might have been really transient and they dissipated. For example, you had pesticides applied in your house, or you painted your house. Well, great. That was really bad when it happened. But if it's 3 months later, we can't measure that. It's gone. Other studies are case control studies where we enroll people at delivery frequently. And again, we need to think about biases that might happen to this very reasonable strategy, because a lot of pregnancy-related outcomes that we want to study are really quite rare. I mean, thank goodness, right? But we might have recall bias that, moms whose babies have experienced something might remember things differently than moms whose didn't. And it's also selecting for a population that delivered. So we would be missing, again, miscarriages or terminations. And we're more likely selecting for populations that deliver in hospitals, because that's where we can find the people, okay? So generally in reproductive epi, we wind up focusing on pregnancy-related exposures and outcomes for women and their babies. We completely ignore the men. This is weird. Sorry, Dr. Varner, right? Like, it's an important component. But it's logistically efficient to focus on the women because they're the ones who are there, right? And it's not the best we can do, though. So one thing that we did in my study that was called HOPE, which is, here's an important tip for all. To have a good study, you also need a good acronym, okay? Right? I hear you. So one thing that we did in HOPE was we did biomonitoring for both partners around the time of ovulation, which could be conception, right? So timing of our environmental exposure assessment is really, really important, because we don't just care that someone had an exposure. We want to know, were they having that exposure like while something biological was happening to them. But this is hard, right? Because stuff that's happening inside our bodies, we may not be so aware of when ovulation is happening, let's say, but we can be aware with education and paying attention. It's a real challenge that by the time a woman notices that she is pregnant by missing periods, whatever, that fetus has experienced a lot of development, that the heart is formed by 22 days and the neural tube is formed by 28 days after conception. So that's why we tell people to take prenatal vitamins, right, before they're pregnant. Because by the time you go to that first trimester visit and they say you're taking prenatal vitamins, right, all that folic acid is not doing anything for the neural tube. Too late, guys. So what we say is that if we really want to do lifetime environmental exposure assessment, it needs to start with both parents at or before conception. You're like, that's crazy, but guess what? I've done it and we're doing it again, okay? If we're ever going to figure out some of the relationships between these acute and transient environmental exposures and how it affects women and babies in pregnancies, then we need to do these exposure assessments at relevant times. And one thing that we did, and I want to say that Karen was a really important part of this way back, was we formulated a really simple educational method to help women and couples learn to identify their fertile window by identifying their own biomarkers. We did a first study, was called Peak Day. We taught women to identify ovulation by changes in cervical fluid. And we were able to show that most women could learn to do this in 2 or fewer menstrual cycles. And then we took that information and actually got an NIH grant to do essentially natural family planning, right? Amazing. So we tried to recruit couples as early as possible in their reproductive journey, taught them Peak Day method, and then had them collect biospecimens based on those biological triggers so that we had them collecting urine, both the man and the woman, around the time of ovulation. Yes, people who are planning pregnancy are different than the people who are like, I'm pregnant. But here's the important part from the science standpoint. If we think that these environmental exposures are going to work the same in people who are planning pregnancy as people who are not, well, then we might as well study the planners. Okay? Like we can learn from them. And then if conception occurred in that cycle, then we actually have biomarkers of exposure at the time of conception and implantation, okay? So what does this really mean? That if they had exposure to some chemical like an endocrine disruptor around the time of conception, if that's a problem, well, then this sort of design is a way to find it. And here's my plain language bottom line. Urine cups are cheap and people are generally willing to collect urine because they're throwing it away anyway. And so our strategy was have people collect a whole lot, keep it in the freezer, and then we'll decide what to analyze later when we know if they're pregnant or not or whatever. So in our study that we called HOPE, which stood for the Home Observation of Periconceptional Exposures, we did a lot of really innovative things where a lot of it was just electronic. We had these posters. You could scan. This is one of the first QR codes like I ever used a long time ago when it was new, that it went straight to our screening form. And we got the IRB to approve people doing like online consenting. Because here's the problem. If you wait for someone to call you and then you get back to them, by the time you get to them, I'm pregnant. It doesn't work, right? So we had to learn how to make all this fast. Well, so did it work? Yes, it totally did. In the end, this happened between 2012 and 2015, and we wound up recruiting 183 couples, which was about half of the people who had screened eligible for our study, because this was a really high burden study. We were asking people to do a whole lot. And I mean, that's just how it is. But among those 183 couples, we wound up with 127 pregnancies, and 53 of those pregnancies occurred during cycles where we were collecting biospecimens. So we actually had urine from mom and dad the day before, the day of conception, and the day after conception that we could study about their environmental exposures when that happened. We went on to have 108 live births and 16 miscarriages. Okay. So did people do it? The answer is yes. We have a paper about our biospecimen compliance, but I'll just give you the highlights that for the urine, it was about 99%, and this is men and women compliance. We collected semen, well, we did, the men collected semen and then they gave it to us. And about at 90% compliance for when we wanted them to do it. We were collecting saliva and that was 97%. We did collect hair at our enrollment visit. And then again, that was 100 because we did it for them, right? We didn't actually collect blood because the whole point of this was stuff that people could do at home. In our new study that I'm going to tell you that we're recruiting for, we are doing blood. Okay. Also important, we put in our consent form that we were going to bank these biospecimens. And so I have freezers full of urine and saliva, and I would be happy to listen if you wanted to collaborate. Okay. And they've already consented to it. So what did we measure all this stuff for? Well, BPA was our main exposure that we were interested in. It's an endocrine disruptor. And at the time that I wrote this grant, it was super hot, so that probably helped it get funded. But it was really just kind of a signal transient chemical, right? Our idea is that in couples, especially where the man had a higher BPA exposure, we thought it would take longer for them to get pregnant. And so that was our main study question. Here's the tricky thing about BPA. It metabolizes really fast. It's like a 6 to 8 hour half-life. So if I had everybody go out and pee in a cup right now, we could know about your BPA exposure like at breakfast, but not 2 days ago. Okay. But it's a prospective cohort, so we captured a whole lot of other stuff. And I'm going to tell you about some of our other findings. We did so one of the things about BPA, like I said, short half-life, you'll read lots of studies where they maybe collected urine twice during pregnancy and then use that to stand for everything. And since we had collected on average 18 to 27 days in a row for women, we were able to do this cool analysis. Kylie was able to do this cool analysis where we figured out that really, if we wanted a stable estimate of somebody's BPA exposure, we probably needed about 6 days in a row, which means that all those other studies where they report one value for the whole pregnancy, you can just kind of laugh at them. Okay. It did turn out that in our study, BPA exposure wasn't a strong predictor of time to pregnancy. We had a lot of very young, healthy people. Oh, well. But we did get a negative result published, so there's that. We found pretty strong relationships between BPA and semen quality, which was super interesting. Almost all of these men did conceive a pregnancy. It only takes, one good sperm. But we did find that if they had higher exposure to endocrine disruptors, they were more likely to have worse semen quality parameters. We also looked at semen quality in relation to air quality. And we're able to distinguish that when men were exposed to air quality disruptions, like we have in Salt Lake City, at different phases of spermatogenesis, it had different effects. Like if in early, it was bad for heads and late was bad for tails or something like that. You can read the paper. But the point is, men matter. And so I want you all not to forget that. Okay. We also did epigenetics on sperm, and we're able to identify some epigenetic differences related to time to pregnancy, again, in young, healthy people who had pretty much all conceived. So here's the most important part that Dr. Stanford wanted me to say first, is that we just started recruiting on a new preconception study. And this is a really powerful way to do early exposure assessment. It can be really efficient way of timing our exposure assessment. For people who are trying to get pregnant, we can teach them when they're ovulating. We can measure around that time. It's better than just having people collect urine every day for their whole lives, right? And we can time it for developmental windows then. If what you're interested in is, say, a birth defect that develops at 5 weeks, well, you can measure then, if you know when they conceived. So here's the important part. We are currently enrolling. If you know anyone who wants to get pregnant, send them my way. Look, there's another QR code. And the end, I'll just say that, again, we really love for collaborators. And that would be both for our new studies and our old studies. And I had 15 minutes and I did it.